Hello, everybody, and welcome to this session of Meet the Specialist. Thank you so much for making time to join us. Today, we have orthopaedic surgeon, Professor John Ireland, who is an amazing guy. He's done more than 4,000 joint replacements. He works predominantly with the hips, knees, and shoulders, but he's also been involved in some complex trauma matters where there's been partial or full amputations and looking at prosthesis. And he's just been so involved in various forums in the orthopaedic world throughout his career. He is highly respected and a very, very valued member of our medical specialist team. Also writes a pretty damn good report, so please make sure you keep him in mind when you are looking for an assessment and report. So without further ado, I will hand over to you and you can tell us all a little bit about yourself. Thank you so much. Hang on a sec, you're on mute, sir. I'm just going to have to unmute you. Do you know how to unmute yourself? At the bottom of the screen, there's a thing.
I'm unmuted now, aren't I? Excellent. Well, thanks for pumping me up there, Michelle. Look, I've been in orthopaedics for over 30 years now. So I trained overseas. I did a lot, mainly in the area of joint replacement, and I've done some clinical research in that area as well. And in the early 2000s, helped set up the Joint Replacement Unit at Fairfield Hospital. And that was with the assistance of the then Minister of Health, Craig Knowles, and he roped in Gough and Margaret Whitlam. So we had a very successful collaboration setting up the Whitlam Joint Replacement Unit and subsequently the research unit there. So they've gone on to be enhanced and supported by the Ingham Foundation, and now Professor Ian Harris runs that side of things. I have continued in clinical practice up to now. So I still do a lot of joint replacement and obviously starting to do more and more in the way of consultancy work, particularly medico-legal assessments, but also medical negligence, and been involved in providing expert opinions for class actions, most notably the Pew ASR some years back. So I've had pretty broad exposure in a lot of different areas. But as Michelle said, most of my work is in shoulders, hips and knees. So I do arthroscopic surgery in those areas as well. I still, having had a background in general orthopaedics, I still see the patients from time to time for assessments for their backs, for their ankles and other joints. I generally stay away from hands and things like that, but still do most areas of orthopaedics.
Wonderful. That is great. I'm wondering, anyone who's joined us here, if you have a question, would you like to unmute yourself and ask your question? Okay. You might be all a bit nervous if you want to do it. I actually have two questions from people who have been unable to attend. And the first is in relation to joint replacements. Yes. They haven't actually said which joint replacements, but just joint replacements. Okay. In the past, there has been a belief that people should wait longer and longer or older and older to get joint replacements, but they are seeing requests for people to have these replacements done younger. What is your view on that?
Well, this probably goes back to that presentation I did a couple of weeks ago, and we've got a registry now of all the joint replacements done in Australia for the last 20 years for hips and knees, and for the last 14 years for shoulders. And what we know out of all that is that survivorship of hip and knee replacements at 20 years is just under 90%. and in shoulders at 14 years is just under 90%. So they're lasting extremely well. There's been constant evolution in the technology and that's utilised in the replacements, but also the techniques that are employed. And so we're kind of getting to that point where if somebody has a hip or a knee replacement and no immediate problems in that sort of perioperative period of about 3 months, and the joint is functioning well 3 months down the track, then we'd be very confident in saying you should get 20+ years out of a knee replacement, which is obviously completely different to what it was 15 years ago and sort of the early period of my practice, because of the quality of from the metallurgy and the other materials we used. Wear rates were a lot higher, and the risk of everything wearing out was much higher. On top of that, also our understanding of the kinematics of the knee weren't as good, and so that over that period of time, things have evolved enormously, and there's been a lot more technology introduced into improving the accuracy of what we do. We're now getting hip replacements that really shouldn't have substantial leg length discrepancies because of the availability of technology. All those sort of things have changed enormously in the last few years. So that's a long answer to a short question, but I hope that gives you a bit of an insight. But
okay.
If you want to find out more, you just look up the Australian Orthopaedic Association National Joint Registry, and there is open access there to the reports, and that'll tell you exactly what's what with joint replacement in broad brush terms.
Great, thank you. All right, and one of the other questions we have is in relation to robot joint replacements. Now they say knees here, but I don't know if other joints are also done by robots. What is your opinion about the comparison of a surgery done by the robot machine or done by an orthopod on their own?
Well, I've had my knee done with a robot, but the whole concept of there being something, an R2D2 on the end of a saw blade trying to do something in your knee, it needs to be sort of looked at in real terms, which means that the robot, all it does is help with the precision of the cuts that you do. It doesn't do the operation. So far, there's nothing in the literature which demonstrates that using a robot and vis-a-vis computer technology is absolutely better than using just the normal handheld guides and instrumentation that we've used traditionally. The only area where it's been shown to be of some benefit tends to be in younger males, but they've been following computer-aided technology for many, many years. Having said that, what has happened in that intervening period is that our understanding of the kinematics of the knee have changed, and the way that people are doing them, knee replacements, has changed quite a bit as well. So I find that I use computer technology. I find that it's actually a very good learning tool. It makes you understand things a lot more carefully. And I think it's part of if you've done hundreds and hundreds of joints just manually with a manual instrumentation, you can be extremely good at it. But if you're trying to refine your technique, sometimes using the computer technology helps you understand where some potential gains can be made. But as I say, trying to demonstrate big differences with a population of humans is very, very difficult. There are just so many variables involved in trying to assess the outcomes that it makes it very difficult to establish any clear benefit of one technique over another.
Right. Okay. Does anyone have a question now that they would like to ask? Did somebody new join us? No, that's looking good. I think we've done well here. So everyone, you've had the chance to meet our lovely Prof John Ireland, who is a terrific guy, writes a great report. And as he mentioned, he did a terrific seminar for us not so long ago, which you can find on our YouTube channel. I encourage you to watch that one. People, you will get the recording of this hopefully later today, but it might be tomorrow. And of course, it will be on our YouTube channel. Thank you all for making the time to join us, and have a great rest of the day.
Thanks a lot.
Thanks so much, John.
Bye, Michelle.
Bye.
See you later.
Thank you.